Dear President, dear moderators, dear all, I would like first to thank you for giving me the opportunity to present you this study entitled Risk Factors of Surgical Site Infection, SSI, after groin hernia repair, GHR, linked to the Club Hernia Registry, and I thank all the members of the Club Hernia Registry for that study. I declare first no conflict of interest. Groin hernia repair, or GHR, is the most frequent intervention performed in elective general surgery worldwide. And we find around 4 to 5% of surgical site infection SSIs after GHR. And few studies in the literature focused on the relevant risk factors of SSIs after GHR. In fact, figures are low and rank from around 1% to 5%. And thanks to a high number of patients involved in these studies, different SSI risk factors have been demonstrated. However, these results are hardly generalizable after scheduled GHR due to selection bias. The aim, the objective of our study was, as a consequence, to specifically study the incidence and risk factors of SSIs in recent elective GHR. The main outcomes was SSIs rates according to patients, but also meshes characteristics within 1 year postoperatively. The secondary outcomes were risk factors of SSIs. So the methodology of our study, it was a French multicenter one with data gathered prospectively on SSIs and related risk factors thanks to the Club Hernia Registry. Criteria of inclusion were all patients over 16 years old who were operated on from GHR between 2012 and 2019. First, results on patients' characteristics. We found around 21,976 patients who were operated from elective GHR. And only 57 patients, that is to say 0.26%, had a SSI. Patients' mean age was around 65 years old, and they were predominantly males. ASA score were low, more than 50% lower than ASA score 2. And the BMI score found were high, for more than 50% higher than 20, that is to say overweight or obese patients. And when we compare the two groups of patients with and without SSIs, we found that considering the wound healing factors, there were no differences and they were comparable concerning these factors. Secondly, the results focused on surgical characteristics. We had around 94% size operated with a mesh, 54% sites were operated laparoscopically, and surgery for recurrences was performed in around 7% of sites. Meshes characteristics were polyester, polypropylene, PTFE meshes, and with micro and macroporous meshes, but most of the time, and more than 50% of the cohort presented, in fact, a mesh of polyester of polypropylene, that is to say, macroporous meshes. And when we compare the two groups, patients with and without meshes, with and without SSIs, we found that they were comparable on surgical characteristics. There were no differences between the two groups. We performed after that a univariate analysis focused on risk factors of SSIs and focusing on patients first. We didn't find any significant differences for either patients or surgical factors. And focusing on sites with a mesh, neither there was no significant differences with surgical factors with higher rates of SSIs. Just one important thing to notice is that for polypropylene mesh, there was a tendency of higher rates of SSIs around 0.25%, and with a P close to the significativity. We then may perform the multivariate analysis for risk factor of SSIs on the macroporous mesh group, as it was the predominant group, and we made it after adjustment on BMI, smoking status, narrow pain infiltration, and type of surgery. And there was no difference in SSI risk. But just an important thing to highlight, that is to say, for overweight patient and polypropylene mesh use, there was a tendency of higher rates of SSI. Consequently, we had here a French multicenter study with around 0.26% of SSIs within a cohort of around 22,000 patients. It's the first one analyzing prospectively scheduled elective surgery and surgery classified as clean without any bone contamination. In the literature, we have just studies of randomized controlled trials with the use of antibioprophylaxis. And in these studies, the SSI rates after GHR are much higher than our results. And we can explain that because of the specialization of the centers and the fact that they were high volume centers. We didn't find any risk factors in our study for SSIs, whereas we had 18 parameters checked. In this very specific topic focused on GHR and SSI risks, the literature in fact is quite poor. And when we analyze them, we can see that most of the time there were only patients' predictive factors of SSIs which are studied. Contrary to our study, where the main advantage was aiming to determine which mesh characteristic would probably impact on SSI rates. And we didn't find any specific mesh features impact of SSI risk, only just a tendency toward less SSIs with polyester macroporous mesh. And we can explain that due to the very low incidence of SSI, despite the large number of cases in our series. And we can say that we have to consider in our work of a type 2 error. In conclusion, we can say that our study specifically focused on elective GHR, contrary to most of the literature, which combines the different types of hernia repair and level of emergency. And despite more than 20,000 patients included, only 57 patients with SSIs were found, and SSI's risk factors were not highlighted. These results suggest first that anatomically speaking, this intervention is at low risk of SSI. And then it is the first clinical study that did not only analyze patient-related risk factors of SSIs after GHR, but also mesh-related factors. And there was a tendency toward higher SSIs with polypropylene meshes uses. But all these results need further evaluation, as SSIs have a significant impact on our healthcare system, economy, and patients' quality of life, and because we know that meshes use is an ever-increasing phenomenon worldwide. Thank you very much for your attention, and I would like to thank you all the Club Hernia. Thank you very much.